This is my first. Okay, so welcome, Professor Ignace de Hingh and Dr. Felice van Erning to the SOGI podcast. We would like to discuss about the population-based data on peritoneal metastases from the Netherlands Cancer Registry, clinical and epidemiological perspective. So the discussion will cover the framework and the functioning of the National Cancer Registry, some general questions on population-based data, and some findings in the papers published from the data of the registry. So just to introduce and to present you, Professor Ignace, you are a oncological surgeon at Catherina Hospital from Eidhoven, specializing in complex oncological procedures such surgery from pancreatic cancer, metastases in the peritoneum. You're the chair integrative approach to patients with gastrointestinal malignancy at Maastricht University. And you are also chairman of the Dutch Peritoneal Oncology Group. You're also member of the Dutch Pancreatic Cancer Group. And last but not least, you are executive board member of the SOGI Group. Dr. Felice van Erning, you work as a researcher, postdoc. You are engaged in scientific research in the field of epidemiology and quality of care of patients with colorectal cancers. You studied health science and public health at Maastricht University, and you have worked on at IKNL since 2012, I think, and spent the first 4 years researching the use and the effect of adjuvant chemotherapy in elderly patients with colorectal cancer. In 2016, you obtained your PhD on this at Erasmus University from Rotterdam. So thank you to accept the invitation and to start on the topic. We start with general question. The Netherlands Cancer Registry is one of the few population-based registry reporting the incidence of and the management of peritoneal metastases. What are the challenge of collecting and reporting the population-based data, for your opinion?
Well, thank you, Laurent, for this kind introduction. And yes, before we start with this very specific question on peritoneal metastasis, maybe Felice would like to address a little bit more about the Dutch Cancer Registry, so the listeners can understand what kind of registry that we do have.
Yes, thank you. The Netherlands Cancer Registry actually started as a regional cancer registry, but since 1989 we have a nationwide Netherlands Cancer Registry in which all patients with a primary malignancy are registered. We obtain this information from the pathological archive and the Dutch hospital discharge database. So the data managers from the NCR collect the data from the electronic patient records in the hospitals. And this entails patient's characteristics, tumor characteristics, and the primary treatments and diagnosis. So specific for peritoneal metastases, I think we are one of the few population-based registries which have information on the metastatic locations, which is, of course, of paramount importance to investigate a specific patient group like this. The NCR is funded by the Ministry of Health. Challenges in collecting are, for example, the use of standardized definitions, changes that might have been taken place over time, and of course, opposite to, for example, trials, the completeness of the data. So it's not always that all data is available. We have missings, often not at random. So these are things to address when reporting on the data.
And if I might add to that, as these cancer registry people are not doctors, they heavily depend on our hospital registration. So we really need to clearly define, as Felice already addressed, what is a peritoneal metastasis, and then it's up to the surgeon to describe it during surgery. It's up to the radiologist, if he sees one on the CT scan, to report it properly. And also for pathologists, it's very important that they really mention it in their pathology report, so that the cancer registry people can get that from the chart and put it into the nationwide registry.
Thanks. And considering peritoneal metastases, for your opinion, what is the epidemiological interest of such registry?
Well, for me personally, I was triggered by the fact that when I started to get some interest, a lot of my colleagues said it's a very rare disease. They said, well, why would you bother about peritoneal metastasis? You only encountered it once in every few patients maybe, but not so much. And that's when I thought to collect the data on this. And I went to one of the predecessors of Felice, and I asked him, can we get this data out of the cancer registry? And we were quite surprised ourselves that we could. We could actually do it quite reliably. And we did see that, for instance, for colorectal cancer, the incidence was 5.9%, which is not maybe a huge number of patients, but still it's a relevant amount of patients. But for instance, for gastric cancer, it's 24% of our patients are diagnosed with synchronous peritoneal metastasis, and so on. Pancreatic cancer, ovarian cancer. So the starting point for me was to see whether it was a relevant problem or not. Well, we determined it was, and from there on, we started with all our studies to investigate the importance of this patient group.
I know that to implement such organization, it's very expensive in specialized skills and human resource. So, do you have support, financial support to help you to organize this structure, or do you have a grant to support this aspect?
Well, yes, as I mentioned before, the Netherlands Cancer Registry is funded by the Ministry of Health. But also, if we want to do specific studies for which we need to collect extra data, for example, then we might need to get some grants. So there are different grant options to receive some funding for our studies. And another point is that in 2019, the Dutch Peritoneal Oncology Group, a working group from the Netherlands, together with the Netherlands Comprehensive Cancer Organization, so which maintains the NCR, we started with a CRS HPAC quality registry. And for this, the expert centers also pay to have these patients registered. So it's teamwork to have this information available for research.
And yes, if I might add to that, it's a lot of money, Laurent, that both government and hospitals are putting into it. But we are evaluated almost yearly whether it's worth the money, and so far everybody's very happy with the investment. We learn so much from cancer in general, not only for peritoneal metastasis, of course, but for many diseases, and that helps in nationwide prevention. That helps to the value of chemotherapeutic treatments into the population base and so on. So a lot of money, but so far more than worth it, I would say.
And is the industry partner are interested to support such organization?
Well, the Dutch Cancer Registry would like to remain as independent as possible.
Oh.
So, the industry would not fund the organization itself, but sometimes, and that's on a project basis. For instance, if they want to evaluate whether a certain medication that proved to be very beneficial in clinical trial also had some impact on the population-based survival, they sometimes provide grants for that. But I think it's a big challenge to remain as independent as possible and still work with the industry on certain projects. So yes, sometimes, but only on project basis.
Okay. So considering colorectal peritoneal metastases, higher than previously reported incidence of synchronous and metachronous peritoneal metastases. What do you infer from this?
From our paper from peritoneal colorectal metastasis, well, for me personally, and I will give the word to Felice afterwards, but for me personally, as a HIPEC surgeon, it was an eye-opener for me that only a small percentage of our peritoneal metastasis patients received CRS and HIPEC. As a CRS and HIPEC surgeon, I would say that would be quite a big part of the patients, especially since in the Netherlands, healthcare is more or less free. You don't have to pay for any treatment, so there are no barriers in that respect. But still, we found out that only about, I would say, 10% of our colorectal peritoneal metastasis patients received CRS and HIPEC. So 90% received some other treatment, which is either systemic, but also quite some patients did not receive any treatment at all. So from my surgical point of view, that was an eye-opener to me. And this also probably explains why the survival of the entire group is still rather disappointing. And if you compare those survival data with about 20 years ago, they did not improve that much. As a HIPEC surgeon, you sometimes get optimistic about survival of 30, 40 months, but that's not true for most of our patients. Felice, I don't know if you want to add something to that.
Yes, another aspect that I think was an eye-opener from that paper is that it was the first time that we also had data available on the metachronous setting. So previously we thought that about 5% of the patients presented with peritoneal metastasis, so this was synchronously. But now we saw that during the years thereafter, another 5% of the patients develops peritoneal metastasis. So it's, yeah, the percentage doubled. So the impact and the burden is even larger than we first thought or knew.
And in summary, you think synchronous peritoneal metastasis from colorectal cancer is represents a higher risk than metachronous peritoneal metastasis?
No, not so much, I think. I think in both groups is about 5%, so that's quite equal. There are some different characteristics maybe from both groups, but I didn't see so much differences in risk factors. Maybe if you look into detail, probably, but if you look to the big picture, I think the chance of developing peritoneal metastasis is equal in patients for synchronous and metachronous cancer, yes.
And so we arrive with a hot topic question about specialized and non-specialized centers. So the your registry data brings out many new findings that are not reported previously. These include patient treated in specialized center and non-specialized center. But you have you have not present any analysis on this. Why?
Yes, well, I think we have actually recently published something on this topic because a few years ago, Koen Rovers found that patients that were diagnosed in a specialized center, so the center that performed CRS HIPEC, patients had a higher odds of undergoing a CRS HIPEC. And I'm sorry, I should have mentioned this is for patients with synchronous colorectal peritoneal metastases. So they had a higher odds of receiving CRS HPEC if they were diagnosed in an expert center, and their overall survival was better. So this was a finding that, of course, was unwanted, and there were several initiatives to reduce this variation. So there were presentations of these results on conferences. The Dutch Peritoneal Oncology group was set up, and last year we repeated this analysis and investigated whether there have been changes in this in the newest period, so from 2016 to 2021, and we actually saw that the odds no longer differed. So whether you're diagnosed in a referral center or in an expert center, the odds of receiving CRS HPEC are the same, and your survival and the overall survival is also the same. So I think this is a very nice example of the impact we made by making this visible.
Sure. And who or how you define in the Netherlands expert center or non-expert center?
Well, that's purely defined on the ability to provide a HPEC treatment. So
Okay.
we started in 2003 in Amsterdam. There was a first center. And then it slowly increased over the Netherlands. And currently we have 8 hospitals in the Netherlands that perform HPEC, and 81 other hospitals that refer their patients to these HPEC centers. And again, as Felice mentioned, there used to be a big inequality between these centers, but thanks to all the efforts that we made, we can now show that the differences are no longer there. And I think, again, this is a very important step forwards, which has been achieved only because we did get the data from the Dutch Cancer Registry. And we were able to evaluate that and improve it. So for a good example, I think, of the value of the Cancer Registry, yes.
Okay. You said there's no significant difference about the incidence of synchronous or metachronous peritoneal metastases in colorectal cancer. And what about the survival outcome from patients with synchronous or metachronous peritoneal metastases? Did you observe difference?
So actually, I think we saw that the survival was comparable between both groups. So we did analysis in which we made corrections for patient and tumor characteristics and treatment. And we actually saw that the setting or the onset of the metastasis, if this was synchronous or metachronous, the survival was the same.
And did you analyze the proportion of mucinous and signet ring cell tumors?
Yes, we also took that into account and saw that patients in the metachronous setting had less mucinous or signet ring cell carcinomas. Signet ring cell was associated with a higher hazard of death compared to adenocarcinomas. But the effect of this on the total group might have been set off by other characteristics, such as that we saw more CRS HPEC in the metachronous group.
Okay. How do you decide on the time frame of the study? For example, 6 months for synchronous versus metachronous peritoneal metastases.
Good question, Laurent. I think that's one of the topics that needs some international definition, standardization, because if you read through different papers, you will see different time points. The way we see it, your synchronous cancer is in the initial diagnosis, including adjuvant chemotherapy and so on. And so more or less after 6 months, your initial treatment is finished. And that's why we decided to start after 6 months to define that as a new metastasis would not have been capable of diagnosing at the time of diagnosis. But very valid question. And I do think for ISSPP and Oncology, this is an interesting topic to get some common ground on and to define these timeframes, yes.
Sure. And the overall outcomes in patients with peritoneal metastases seem dismal, with a median overall survival of 9.1 months. This is similar to what we report in Lyon with the study called EvoCap many years ago. How do you put this into perspective, considering that only 8% with synchronous and 16% with metachronous peritoneal metastases had cytoreductive surgery in association with IPEC?
Mm-hmm. Yeah, I do think this is one of the biggest advantages of cancer registries that are population based, because again, as a HIPEC surgeon, if I look to my results 36 months and then compare them to the results in Lyon from 20 years ago, I would be very, very satisfied and happy. And now I realize that I only report about a very small percentage of our patients, that the vast majority actually receive systemic therapy or no therapy at all, and that for the entire group it's still 9 months. So if anything, we need to pay more attention for those patients who do not receive CRS and HIPEC. How can we improve their prognosis? For instance, better systemic treatment, new drugs that are specifically targeting peritoneal metastasis, and so on. So the fact that we do population-based studies, it puts everything into perspective and sees the areas of need.
Okay. Concerning gastric peritoneal metastasis, what is your opinion as a surgeon and as an epidemiologist about the study that we call the observational cohort studies, surgical cohort studies? For your part, what is the interest of these studies, and which are the most useful for you, surgeon and epidemiologist?
Well, as an epidemiologist, I think both serve their own purposes. So it's very dependent of your research question, what type of study you would prefer. I think advantages of observational cohort studies, as based on the data from the Netherlands Cancer Registry or other registries, is that you have the full population in target. So not just the subgroup that receives a certain treatment or surgery, but you can take everything into account. And especially in a patient group with peritoneal metastasis, we now know that only a minority is eligible for surgical treatment. So the observational studies give us the opportunity to investigate other aspects as well. On the other hand, if you're researching specifically a surgical cohort, then of course it might be more useful to have a surgical cohort study with more detailed information about the procedure.
Yeah, and from a surgical point of view, I was really amazed by the enormous amount of patients with peritoneal metastasis. As I said, colorectal maybe 10%, but this is really about 30% of patients that are affected by peritoneal metastasis. Fortunately for Western Europe, and I think also for the USA, gastric cancer is declining. But I had the honor to visit, for instance, China 2 weeks ago, and there it's an extremely important disease. For them, it's really, really a big topic to address the problem of peritoneal metastasis in gastric cancer, both in terms of treatment, but probably even more interesting in order of prevention of peritoneal metastasis. So we were capable of showing the magnitude of the problem. I do think that it's for others to design studies how to treat them, and especially how to prevent them in the future.
And do you think that the data from the National Cancer Registry used to create awareness among different targets as a primary physician or patient organization or health policy?
And definitely. Again, I started 15 years ago. Everybody said it's a rare disease. You should not bother. There's nothing to be done about. Currently, there is a really flourishing scientific community starting up, and more centers around the world like gaining interest. And it started maybe with surgical interest, but I do see, fortunately, also more and more radiologists, gynecologists, medical oncologists into the field. And the most exciting thing I do think is that also the translational research partners are getting more and more involved in the treatment of peritoneal metastasis, as they do see this is a huge challenge. Previously, it was all about liver and lung metastasis, but now there are big labs in the Netherlands, and I do know also in Europe and in the world that are really getting interest in this disease because they see the magnitude of the problem and the impact of the quality of life.
Yes, and maybe to add, I think we collaborate with healthcare professionals, but also with policymakers and patients. The study we described before about the differences between referral centers and expert centers is a nice example of how we inform the healthcare professionals about results and how this can have an impact. For example, other ways is that we also provide facts and figures about cancer to the public, and policymakers use our data to see the burden of or the impact of the disease.
And you said that peritoneal metastasis, the rate of peritoneal metastases is very important in gastric cancer. More than 13% at the diagnosis stage and 20% during the follow-up of patients. So do you think this data from National Cancer Registry and these findings can contribute to the prevention action among the different specialists and the different physicians?
Yeah, sure. To mention some projects that are being designed around the world, we do now see that patients in high risk patients, for instance, the T4 diffuse cancer types, we know that they have a huge risk of peritoneal metastasis. Now research groups are trying to treat them prophylactically with IP chemotherapy before surgery, as an adjuvant to surgery, maybe a preventive PIPEC procedure, and so on. The fact that we, amongst others, of course, did find that this is such a relevant problem with such a huge impact on the survival of these patients that urges other people to look for solutions. And very fortunately, there are some clinical trials now going on, small ones, but yet more and more to come, I guess, in the near future.
And now I would like to discuss about a subgroup of patients that we talk in some papers. It's about the peritoneal metastases of hepatopancreatico-biliary origin. In this population, the average age at diagnosis is around 70 years. So, for your opinion, how does this parameters affect the treatment strategy choice?
Well, good question again, because we did do this study just in the first time to see whether it's a relevant problem or not. If only very, very few patients are affected, it's not really worthwhile maybe to make a big deal out of it. But we did see that quite some patients develop peritoneal metastasis from this disease as well. For instance, pancreatic cancer patients, they have 14% at the time of diagnosis already peritoneal metastasis. So we did see that, and now your question is how to treat them, and that is an extremely important challenge. And that is, for instance, because their survival at this moment of time, it's only 2 months. So that's a really dramatic survival of these patients. So, before you can start a proper treatment, most patients have died actually. So This type of research is in the first place to be seen as exploratory. How important is a problem? Well, we defined it is important, but a treatment challenge remains as the survival is so poor. And well, I could not believe my eyes when I saw this survival graphs for the first time. It's less than 2 months if you don't get treatment. It's showing the dramatic impact of this disease in these patients.
Yes, and if I may add, might also be good to mention that age on its own is not a criteria for treatment in the Netherlands, but of course it is very much related to the physical status of the patient and comorbidities. So in a young or in an elderly population, we often see there are some less treatments. But also we know from other studies that elderly patients are also more often decide that they don't want to be treated anymore. So this is another aspect, but especially in this group, of course, the disease is often discovered very late and curative therapy is often not possible.
Yeah. But do you observe change or maybe evolution in the practice, in the treatment? Maybe now we propose curative treatment easier than many years ago, or there is a big challenge, a big clinical challenge, this subpopulation.
In general, we see, and that's over all peritoneal metastases from all origins, we see a higher tendency to treat with systemic therapy. So patients are increasingly treated with systemic therapy as a cancer-directed treatment, but I would say mostly in a palliative setting. And unfortunately, the impact on survival of the entire group is not very high. So it remains a challenge to get the right treatment for these patients. And a curative treatment, apart from colon, apart from appendix, apart from ovarian, and some gastric cancer patients, remains very challenging.
Okay. Just to come back to the general consideration about the registry. Felice, you said that the importance of the pathological data, because this data are allow you to register cases and to label cases in the registry. Did you organize a pathological central review in some cases that where diagnosis is very complex or is uncertain?
No, this is not standardly done. So there are different pathological archives or labs in the Netherlands. They all serve a certain amount of hospitals. There's not one central in the Netherlands.
We do collect all our data centrally. So there's one central collection, but there's no central pathological review, apart from very rare diseases. Of terminology and definitions through PA labs, pathology labs, I should say. So for instance, if they are referred to our center, we ask our own experienced pathologists to review these cases. But nationwide, it's only for rare diseases, such as mesothelioma, and for instance, also for sarcoma and so on.
Yeah. So you are a similar organization that we have in France for complex and rare disease. We organize pathological review only for these cases.
Mhm.
So and after, how do you to proceed to analyze the data from the register? Do you have a biostatistic task force to help you to analyze this data, or maybe Felice, you manage this process?
Well, yes, this really depends on the research question and where did it came from, but it's always teamwork between epidemiologists, healthcare professionals, and if needed, a statistician. So yeah, we really start with what is the question, how can we best investigate this, do we have the necessary data for it, and then make our research plan.
Yeah, same as in hospital, it's teamwork. And we are very happy that we have some excellent epidemiologists in the NCR. So we as physicians can ask questions and they can tell us whether or not that's achievable, because not everything, of course, is doable with population-based data, and we need to know the limits and the possibilities. But together we come a long way, I would say.
And what about the patient contribution to the registry? Are they involved in the registry, in the data collect, or in the conception?
Yes, we have a patient advocacy group that's part of our organization, and also when we perform studies, we try to involve patient representatives and also provide study results at meetings they might organize. So we have, I think we have good contact with several patient support groups.
If we want to ask for a grant, we don't have any chance if we do not have the support of the patient groups. They really have to be involved. They have to see, because we as doctors might something important very differently than from a patient perspective. So I do think their view on our research is very interesting. It makes you look through other eyes. For instance, they are very much into quality of life, to PROMs, to PREMs, and so on. Important topics that we as doctors might not think immediately on. So yeah, I think it's important to get them involved.
And concerning the patients, do you meet patients do not want to that their clinical data not to be collected and not to be shared in research projects? Do you meet some patients like this?
Well, yes, patients always have the opportunity to opt out of our cancer registry. So patients are informed about the cancer registry in the hospitals. There are flyers to inform them about that, and they always have the right to ask for their data, to see it, but also to opt out if they don't want their data to be included. But I think that it's only rarely that a patient asks for this.
And we are in a very fortunate situation so far that we do not have to have active permission of patients. So for the NCR, at this moment of time, it's running in the hospitals and patients have to actively opt out. That might change in the future, but currently they do not have to actively agree with participation in population-based studies.
Okay. And for your opinion, what is the future that we can write for the National Cancer Registry? What is the next step or the next evolution?
Well, I think a nice development we're working on right now, specifically for the patients who undergo a CRS HIPAC for colorectal peritoneal metastasis, is that we are going to collect follow-up data. So until now, for most patients, we only know what their primary treatment was. But for these patients, 3 years later, we will go back to the electronic patient records and see how patients, how it was after the primary treatment. So did they get any recurrence or progression, and was it treated? So I think this will help us in establishing a more overall view of the real burden. So that's really on the content. Another practical development is that we are working on automatic data extraction, because now everything is done manually, and this might save a lot of time and prevent errors. So I think for the total cancer registry, this is also a very important development.
I have still a question. You know that patient report outcome or patient report experience are very important, and many articles treat about this new and innovative aspect. Do you think in the National Cancer Registry, because it's real life data, do you think it's relevant to include this kind of data of PRO or PREMS data in the registry? Because I know that it's not very easy to have this kind of data. Do you think there is an interest to include this kind of data?
Yes, I certainly do. Very important part, the patient-reported outcomes, especially in this patient group. And for a part, we already collect this data. We have the prospective Dutch colorectal cancer cohort, and patients that are included in this cohort receive patient questionnaires with patient-reported outcomes. So this data is collected. We already have published some results on this, but of course, because the group of peritoneal metastases is limited, it takes some time to establish a group that we can investigate. So I think this is very important, and it has our attention, and we will definitely look into this more in the future.
Yeah, and these are the studies that, of course, they need informed consent of patients. So it needs a little bit extra energy from the doctors to include these patients, and especially from the patients who fill out these questionnaires. But the combination of PROs, PREMs, and population-based data, well, I think that gives us invaluable information, and in the future we are collecting that, and will give us a very important insight. And also it gives us a possibility maybe in the future to also perform trial within cohort studies instead of randomized controlled trials. It might be easier to achieve, it might be cheaper to do, but again, it's a relatively new design, and it would be very interesting for patients with peritoneal metastases as well. So we are looking into that at the moment.
And just to conclude, I don't resist to ask you a question about the intelligence artificial. How do you imagine that data from National Cancer Registry can be used in artificial intelligence approach? Because we know that in artificial intelligence approach, you need to have big data, and I think this kind of organization, this kind of registry, can give a lot of data that we can explore with a different approach. So, what is your opinion about artificial intelligence and cancer registry?
Well, yeah, I think it's there and we need to use it. It's not my area of expertise, but we do have data scientists working at NCR as well. And I think they are working on developments in this area.
Yeah, for instance, with these data, you can compare also outcome between countries. And for instance, with France or with the United States, you also have cancer registries, and by doing so, you can see patterns. How are your patients in France treated? How are the Netherlands treated in the United States? And what is the difference in outcome? And these huge data, well, they are not to be captured by the human mind. I guess we need help of artificial intelligence to understand these patterns, to make a connection between certain patterns and outcomes that we might not see at the first place. So yes, I do think that's the future and something that we are working on. But as Felice said, we have some very smart guys working on that, and maybe that will be something for our next podcast, Laurent.
Yeah. Okay. Thank you. Thanks a lot, Felice and Ignace, for your time, and thank you for your answers to the question. Many thanks for your availability, and it's a great pleasure. It was a great pleasure to discuss with you about this registry, this organization, and congrats for all this work that you have done in the Netherlands. So thank you very much. Bye bye.
Well, thank you, Laurent and Aditi. Thank you.